Hey guys, Yulia back with Nerdy NP, and today we'll be talking about ACEs, ARNIs, and ARBs. So first off, with talking about these classes of medications, we have to discuss the RAAS system, and that stands for Renin-Angiotensin-Aldosterone System. And this system is intended to raise your blood pressure, and it's usually very effective in hypovolemic states where you may be losing blood, or you may be, let's say, in septic shock, so all of your vessels may be very dilated and your blood pressure might be low. And so this system helps to support blood pressure and to maintain perfusion of vital organs. However, in heart failure, it does help us for a little while, but then it actually causes more harm than good. And so these medications essentially block this system, which then helps to relieve some of these heart failure symptoms, and that's what we will talk about now. So first we'll talk about ACE inhibitors. ACE is an enzyme that is produced in the lungs, and it actually helps to convert angiotensin 1 into angiotensin 2. And angiotensin 2 then binds to AT1 receptors on the blood vessels, and it causes vasoconstriction. And so when we have vasoconstriction, obviously we have an increase in blood pressure. So what ACE inhibitors do is they block the conversion of angiotensin 1 into angiotensin 2 by inhibiting this enzyme called ACE. And so you have less angiotensin 2 than binding to AT1 receptors and causing vasoconstriction. And so you get the opposite effect, which is vasodilation. And this lowers blood pressure, which lowers afterload and reduces the strain on the heart and how hard the heart has to pump to get blood out to the rest of the organs. So common examples of ACE inhibitors include things like ramipril, lisinopril, enalapril, and so those are the most common types. And then you also have your ARBs, which is your angiotensin receptor blocker. And essentially they also decrease afterload and lead to lower blood pressure, but a little bit of a different mechanism. So the angiotensin receptor blockers bind to the AT1 receptors on the blood vessels, and they block the binding of angiotensin 2 to those receptors, and so that's how they mediate vasodilation and mediate a drop in your blood pressure and a decrease in afterload. And then finally, we have your ARNI, which is your combination of an ARB and a neprilysin inhibitor. And so the most common one, the only one, is called Entresto. And the way it works is obviously ARB we already discussed. We know how that lowers blood pressure, but neprilysin inhibitor is just like an additive. So neprilysin actually is an enzyme that degrades natriuretic peptide. Brain natriuretic peptide is a protein that is released by the heart, and it's released when the heart is stretched. So when the walls of the heart are stretched, it induces the release of this natriuretic peptide. And what that does is it has like a diuretic effect where it makes you pee out more fluid. And so when neprilysin is around, it actually degrades this natriuretic peptide. And so you don't get this diuretic effect. And so we don't really necessarily want that with heart failure, because we want to diurese, we want to get fluid off, we want to lower preload, we want to lower the stress on the heart. And so by giving a neprilysin inhibitor, we actually impair the degradation of natriuretic peptide. So then natriuretic peptide stays in the body longer, and it produces more of this diuresing effect, and it lowers your blood volume and your preload, which then obviously reduces the strain on the heart and improves heart failure symptoms. So valsartan sacubitril is Entresto, and that's the only drug on the market that is an ARNI that we currently use for heart failure. So just to sum it up, all of these medications work on the RAAS system. They all lower preload and afterload. So one thing to keep in mind with all of these medications, ARNIs, ARBs, ACE inhibitors, is that They all have the same side effect, which is hyperkalemia. And the reason why this happens is because angiotensin 2 stimulates the release of aldosterone, and aldosterone works on the kidney to essentially reabsorb more sodium into the blood and to excrete more potassium into the urine. And this is helpful when we have low blood pressure because obviously water follows sodium. So when sodium is reabsorbed back into the bloodstream with the help of aldosterone, water goes with it, and that elevates our blood pressure. But in heart failure symptoms, we don't necessarily need a higher afterload. So by blocking the aldosterone, we cause more sodium to be released in the urine, but unfortunately, the other side of that is more potassium goes into the blood and causes hyperkalemia. And as we know, hyperkalemia can cause dangerous arrhythmias, cardiac arrest, and death. So we would never want to start all of these medications. We would never want anyone to be on all of these medications at once. And if, let's say, we were transitioning somebody from, let's say, an ARB or an ACE inhibitor to an ARNI, we would want to stop the ACE and ARB for at least 36 hours for the patient to have a washout period to get the medication out of their system to prevent hyperkalemia that would be life-threatening to them. And the reason why we may want to transition someone in a worsening heart failure to an ARNI is because we have that combination of an ARB and we have the naprolysin inhibitor, the sacubitril, and the combined effect of those two medications is better than just ACE or ARBs alone. So that may be why we would be transitioning a patient. But again, we want to make sure we have that 36-hour washout period, and we never want to simultaneously give any of those medications to the patient. So that is essentially ACEs, ARNIs, and ARBs in a nutshell. And I hope you enjoyed this video, and I will see you in the next one.